Good afternoon, everyone. We'll wait about 1 minute before we get started. Thank you for being here. Good afternoon as you're joining. We'll get started in a few seconds. Good afternoon, everyone, and welcome to today's Harvard University Center for AIDS Research webinar, Migration and Resettlement Health in Massachusetts, Dismantling Stigma, Delivering Care. My name is Aima Ahankai, and I'm the director of the Community Engaged Research Program at the Harvard CFAR. It's my privilege to open this important discussion on a topic that is both timely and critical for our community. As you may know, Massachusetts is the only state in the country with the right to shelter law. This law requires state officials to quickly provide shelter to homeless families. And I'm sure we're all well aware of the increased influx of migrant families arriving in Massachusetts. The journey of migration and resettlement is layered and complex and may come with significant health challenges. Our community here today has rich expertise in disease prevention, health promotion, and healthcare delivery, and a deep commitment to serving our communities. In addition, as a CFAR, we've become quite familiar with the challenges posed in delivering effective care to stigmatized and often minoritized and marginalized individuals. Today's webinar brings together distinguished experts, including Dr. Amir Mohareb, Director of the Research Program on Humanitarian Action, Global Migration, and Infectious Diseases at Mass General Hospital, Dr. Dylan Tierney, Associate Medical Director of the Bureau of Infectious Diseases and Laboratory Sciences at the Massachusetts Department of Public Health. And from Boston Healthcare for the Homeless Program, we welcome their health equity leader, Yesenia Mejia Urieta, and one of their stellar primary care providers, Dr. Margaret Sullivan. Our goal is to provide this audience with a better understanding of the health issues affecting migrants from these clinical, public health, and community-based perspectives, and to highlight the challenges, best practices, and innovative solutions that are being explored and implemented to overcome stigma and meet the health needs of newly arrived families. This is a wonderful audience, half of whom are currently working with immigrant communities. And as we move through today's program, I encourage you to think about the ways in which we can bring our own strengths to the table and ignite further action for this public health priority. Our goal and hope is that this conversation will not begin and end here. Thank you for joining us. Please feel free to put your questions in the chat throughout. We will hold the formal question and answer to the end. I'll now turn the microphone over to Dr. Mohareb.
Thank you so much, Dr. Ahankai, and I am very grateful to the Harvard University Center for AIDS Research for opening up this valuable space where I can learn from the colleagues who are on this call today and from, of course, from all of our participants. We have a lot to talk about in a short hour, so I'm going to share my screen and get started with a brief overview before we have the other speakers discuss their areas of expertise. So before we get started, I want to introduce some refugee health and immigrant health terminology. These terms that I'm introducing here are, largely delineated, defined, and designated by international organizations like the UN High Commissioner for Refugees, UNHCR. And there's somewhat legal definitions as well. So a refugee is a person who flees their country because of a well-founded fear of persecution, war, violence. And that is slightly different from an asylum seeker, someone who's already left their country and application and is applying for that protected status, and that application is in process. And then another category of a person who would be, you know, forcibly displaced from their home is an internally displaced person, someone who's displaced within their own country. Sometimes in the media, that is distinguished from economic migrants or people who are seeking a better economic opportunity in another country. But I will say, as a physician, to me, some of these categories might be a little reductive because actually the motivation to migrate can include many different reasons. It can include past discrimination, fear of violence, climate change, and seeking and fleeing poverty or seeking a better economic opportunity as well. So taking a picture of what's happening in the Western Hemisphere, there are multiple routes of, and I'll say largely irregular routes of migration across Central and South America and Mexico for individuals who are seeking to migrate and seek asylum in the United States. One of the reasons that this is so variable is because many countries across North, South, Central, and South America just have very different and frequently changing visa rules. And so a family or a person who's migrating has to understand based on their country of origin, what finances they have available, how they can migrate from one place to another to arrive safely. There are two areas of interest I think for many of us in migration health in this scheme. One is the Darien Jungle, or the so-called Darien Gap, which is the area between the countries of Panama and Colombia. And the other is really at the US-Mexico border, where a number of different rules have and policies have been put in place over several years, essentially restricting how people can seek asylum in the United States. So I'll talk about these very briefly. In the Darien Gap, this is an area of dense rainforest between Panama and Colombia. So there's actually no land connection or road between these two countries. It's really this rainforest. More than 500,000 people crossed the Darien Gap in 2023, and many of them were subjected to exposure to hostile natural elements and large amounts of environmental waste and damage in the process. Written by some colleagues of mine, a review of the journey in transit through the Darien Jungle, which they likened to Dante's Inferno, and then purgatory, meaning waiting for permanent status, either at the border or in detention facilities or so on. And here are some of the risks that people traveling are facing in this one part of the migration route. More recently, there have been several reports of a sharp rise in sexual violence among people crossing the Darien Gap, and this has been, widely documented and largely by Médecins Sans Frontières over the last few months. I was lucky to visit and work in the Darien Gap last year, along with Dr. Jose Pachar Lucio, who is the director for the Institute for Forensic Medicine in Panama, who is responsible for conducting autopsies on human remains of individuals that are found, migrating people that are found in the province of Darien. And so many people die in this very dangerous migration route, and a small fraction of them have their human remains safely recovered, and a fraction of those actually get autopsies. And so what we found was a substantial percentage of those remains were actually of children and adolescents. In the most cases, we were unable to identify a cause of death, largely because in this tropical humid climate, individuals, the remains actually decompose quite quickly. But there was evidence of gunshot wound stabbings, and drownings were common as well. After crossing through the Darien Jungle and across Central America, migrating people often try to approach the US-Mexico border, which is a vast land border. At Massachusetts General Hospital, through the Center for Global Health, we have a relationship with humanitarian relief organizations that work at the Texas-Mexico border in the Rio Grande Valley. There are large informal encampments of this highly mobile population with minimal involvement from traditional international relief organizations, though some operate there, and largely rely on local charities and community-based organizations for support. This is a picture of the Rio Grande. This is the river that separates Texas from Mexico. And you could see kind of just an informal growth of tents encampments across that river. Here are other photographs that show the conditions that individuals live in. This is, both of these camps our team has worked in, and I really distinguish them because in this photo on top, you could see some portable toileting facilities, a large amount of waste and areas of open defecation, and just an exposure very close to the river where, flooding and extreme weather events can harm the population. The main difference with that and the photograph on the bottom is really that the local charities were able to build a wall, which the idea is it dramatically reduces the risk of violence and particularly sexual violence for the people living in the encampment, though water, sanitation, and hygiene is still a major issue. Here's a patient I saw in their clinic a couple of years ago who had unfortunately suffered a gunshot wound to the head. Many of these individuals and families had just crossed the Darien jungle. This is a more recent picture of a cluster of varicella cases that we saw in the camp. After arriving into the United States, individuals are bused or otherwise transported to a variety of cities across the country, Chicago, Washington, D.C., New York, and of course here in Massachusetts. I'll show some work in progress from one of my colleagues in Manhattan who cares for a large number of sheltered asylum seekers in New York City. This is a survey that we did of more than 500 individuals in Manhattan who were homeless, many of whom had, all of whom had crossed the southern US border, and the majority of them I show here actually had crossed the Darien jungle. My colleagues there also asked them about their migration experiences. So not their experiences prompting migration or prior to leaving their home country, but actually while they were migrating. And you could see a high percentage of reported physical assault, sexual assault, kidnappings, extortion, and illness along the routes. The majority of people are incarcerated or detained after arriving into the United States. And doing, this is a multivariable logistic regression we did to try to understand the factors associated with these events. And crossing the Darien Gap was the factor that was most associated with any of these individual hazards. In a larger sample, they've done medical screening, including screening for HIV and sexually transmitted infections, where you see among those people who completed testing, this is in their initial visit upon arriving into New York, there is a substantial percentage that test positive for syphilis, chlamydia, HIV, a smaller amount for gonorrhea. This is a little higher than what we see nationally in people who are resettled through the U.S. Refugee Resettlement Program. And the risk of these infections actually continues or sometimes actually increases after resettlement, particularly depending on the structures that they are in, incarceration, homelessness, poverty, and so on. There was also testing for susceptibility to vaccine-preventable infections. These are all individuals who live in congregate shelters. More than 1,000 people who were tested last year. There was a substantial percentage who were non-immune by serologic testing to these vaccine-preventable infections. And in other parts of the country, we are seeing outbreaks of those infections. And so transitioning then to Massachusetts, there's been challenges to the response to these newly arrived families in Massachusetts. And I'll point people who are interested to this great review article by Dr. Fiona Danaher and colleagues at the Center for Immigrant Health at the Massachusetts General Hospital that outlines it quite well. But in the middle of fragmented social policies of differing healthcare access depending on which ACO someone is enrolled in, housing and shelter access being limited, education and poverty, and to add on top of that, stigma, institutional mistrust, and the mobile nature of the population, which I'm sure we're going to hear more about from our other speakers. So I just wanted to provide that context, and I'm sure we'll discuss more in detail about each of these issues, including the stigma and the challenges addressing migration and resettlement here in Massachusetts. Well, I could turn it over to our next speaker, Dr. Dylan Tierney.
Thanks. Hi, everyone. You should be seeing my screen now. Great. So I just want to thank CFAR at the start for the opportunity to be a part of this important webinar. It's a real honor for me to be here today. I've learned a lot from mentors at CFAR over the years. Today I'm going to be talking to you about the Massachusetts Department of Public Health's response to increased migration in Massachusetts. And I'm going to specifically focus on work by the Bureau of Infectious Disease and Laboratory Sciences, where I am serving as Associate Medical Director. And that work in its relation to ensuring the public's health with regards to migrant families living in emergency assistance shelter. So I'm going to try my very best to use non-stigmatizing language throughout my presentation, but please assume best intentions if I happen to slip up, because I think that the topic is quite complicated in how we refer to people staying in emergency assistance shelters. Okay, so I think the first question that is on many people's minds is, what is the scale of recent migration into the state? How big is this issue? And I would say that it is a difficult question to answer. And I think primarily it's difficult because people in our country have freedom of movement, and they do not register their presence in a community when they arrive. So coming up with accurate counts of people moving in and out of the state at any time is difficult. But we are in the midst of a global migration crisis. In 2022, there were 30 million refugees around the world and 100 million displaced people. That is 1.2% of the global population who is displaced. So those are massive numbers. There were 3.1 million attempted crossings at the U.S. southern border in 2023. And the individuals who attempted to cross mostly came from Guatemala, Haiti, El Salvador, Honduras, Nicaragua, and Venezuela. So when we want to think about what's happening in Massachusetts, the best counts that we can come up with are people who have been seeking emergency shelter, the number of families that are staying in emergency shelter. And I will go over those numbers in a little bit. But there are many other people who are arriving in the state that are not staying in state-supported housing. They may be staying with friends or family. They may have found housing on their own, or they may be staying in homeless shelters. And we don't have great insight or visibility into the numbers of those people. Just another note, Dr. Maharab also mentioned is about legal status. So in the big picture here, I think we're talking about essentially asylum seekers. And so these are people who are seeking protection from dangers in their home country, and they're applying for refugee status, but it has not been determined. So most of the people coming across the southern border and making their way to Massachusetts are people who are seeking asylum. And so synonymous with asylum seekers are people who are humanitarian parolees. They don't fit within an existing immigration category, meaning that they're not visa eligible. They have sort of a discretionary status. And this parolee status lasts only for 1 or 2 years, and they need to apply for asylum, and asylum needs to be determined within that period. So most people that are here are sort of waiting for a determination of asylum. Also, to kind of complicate the situation, there are special statuses for certain people who are arriving. And one of those is being a Cuban Haitian entrant. So Cuban Haitian entrants have special status, and they may be eligible for some benefits that are afforded to refugees, capital R refugees, that meet the kind of classic definition, or the and so those benefits include eligibility for mass health. Also, work authorization depends on your designated immigration status. So there's complex rules and laws around immigration status. I'm not an immigration lawyer, so I'm going to skirt around that gracefully. But I'm going to be focusing mostly on the Department of Public Health's response to people staying in emergency shelter. So as already mentioned, in Massachusetts, we have a right to shelter law. So we became the only state to guarantee a right to shelter law in 1983. And we are still the only state that has a right to shelter law. New York City also has a right to shelter law, but we're the only state that has one. It generally applies to parents and guardians with a minor age child or a pregnant person who meets a certain poverty level criteria and who does not have shelter. So there are some qualifications criteria. The number of families that have been living in state-funded shelters has increased dramatically over the past year or so. There was an 80% increase in people seeking shelter from 2022 to 2023. So that increase led Governor Maura Healey to declare a state of emergency in August of 2023. And that state of emergency allowed for the expansion of our shelter, emergency assistance shelter system, to include hotels and other sites, mass sheltering sites. In addition, it led to the activation of state agencies. And so multiple executive offices within state government began to focus their attention on this problem. So the Executive Office of Health and Human Services, which includes the Department of Public Health, the Office of Preparedness and Emergency Management, Office of Local and Regional Health, Office of Refugees and Immigrants, Department of Children and Families, along with the Executive Office of Housing and Livable Communities, Executive Office of Education, and so it's Executive Office of Labor and Workforce Development, a really large state government response. But that's all to say that there is a lot of work being done outside of the Department of Public Health's work that I will not be covering. And in addition to the activation of state agencies, the declaration of emergency also led to the coordination of a network of non-governmental organizations, including healthcare facilities like hospitals and community health centers, direct service organizations, including the United Way and the Boston Foundation, to the biggest and most important, and then community-based organizations and faith-based organizations. So thinking about emergency assistance shelters for a moment. So, as I said, these have been existing since 1983. There is a large network of them across the state. There's over 1,200 shelters around the state, and across those 1,200 plus shelters, there's approximately 7,500 families that are staying in these shelters. The majority of those families are recently arrived individuals, parents and guardians with minor age children or pregnant people, but not 100%. There are other families that are staying there, who have been in the U.S. or in Massachusetts for a long time. Most of these shelters are small. They're houses or apartments, kind of like think about your classic triple decker in Cambridge or one of the neighborhoods in Boston. But there are some large shelters. So there's hotel sites with greater than 10 families. There's 67 of those, and those are also scattered around the state, in Metro Boston, Southeast Massachusetts, Central Massachusetts, primarily, and then north of Boston. These shelters can either be supported by a shelter supporting organization like La Colaborativa, or they can be unsupported. So the smaller shelters may be unsupported. And these shelter supports, they'll sort of serve the purpose of kind of administrative role, maintaining rosters of people that are staying in the shelter, delivering services like food and informational services as well. We also have within the kind of galaxy of shelters, there are shelters that are designated for individuals with medical needs. So people with a third trimester pregnancy, or sort of complex medical conditions that require medications that need refrigeration or something like that. On the rare occasion, thankfully rare occasion, that there have been infectious disease outbreaks in shelters, or outbreak is a strong word, where there have been instances where people have a contagious infectious disease, those medical sites are also available for people to stay there. So, for example, we had a couple cases of varicella in one of our shelters, and then for isolation, those individuals were given space at kind of these EA sites, emergency assistance shelter sites with medical capacity. Most of the time, so that number 7,500, it fluctuates a little bit because people eventually, hopefully, will move out of shelter and into somewhere more stable to live. But that is all to say that the shelter sites are currently at capacity. So we are capped at 7,500 families staying in shelters. That's about 24,000 people, because family unit is more than one. If you do not have, if you're not staying in a shelter, but you qualify for a shelter, you're put on a wait list. And those who are waiting can stay at temporary overflow shelters. There are a number of them around the state. What's pictured here is the Milnia ACAS Recreation Complex, which is actually being in the process of being stood down, but serves as a dormitory style shelter for people who are waiting to get into a kind of more formal EA shelter. Important aspect of the temporary overflow shelters is that there's a recertification that's required. It was really just kind of implemented. This is the first month it's being implemented, but it is intended for people who are staying in these overflow shelters to engage with case management and other services that will help them to be rehoused more quickly. So things like English language classes, and they are recertified monthly, so they can kind of continue to remain on the wait list. Unfortunately, these sites are also full, and so for individuals that are not able to gain access into the temporary overflow shelter, then we have another category, which is I'm referring to as a sort of the last safe place where they had been, and so this includes Boston Logan International Airport, which has been in the news. We have about 300 families staying there currently. That number sort of rises slowly as more and more people arrive. But it's for people that, again, are on the wait list but have no other housing options. So these individuals, they're transported to a family welcome center during the day, where they are fed and have access to other support services. So there are a number of sites being considered for expansion of this. One of them is the decommissioned Norfolk prison, and the idea there would be it would serve as a site for an expanded site for housing for people who are not on who are not in these overflow sites. So when we think about public health responsibilities and priorities for people staying in emergency assistance shelter, as an infectious disease physician, my mind goes pretty quickly to the infectious diseases of public health importance and those that can spread between people in congregate settings. I'm going to give you a few examples of some of the activities that we have undertaken as a bureau and as a Department of Public Health to address these concerns. So thinking back, first example will be thinking back to the last late summer and early fall when just after Governor Healy had declared the state of emergency. So we began to plan for a screening event that was focused on making sure children were able to enter school safely. And so, what is required generally is that they be up to date on their childhood immunizations, they be screened for tuberculosis, and they have a lead screening. Just to mention that it is possible for children, homeless children, to enter into public education through the McKinney-Vento Act without having documentation of immunization or proof of residence, but we still felt like it was a priority to get this done as quickly as possible. So in a joint effort between the Bureau of Infectious Disease and Laboratory Sciences, the Office of Preparedness and Emergency Management, Office of Local Regional Health, and the Commissioner's Office at DPH, we undertook a shelter-based screening approach at some of these EA shelter sites. And so people were screened for TB exposure and for lead exposure, and this was paired with vaccination clinics that were offered by Cataldo Ambulance Service. There were patient navigators on site along with interpreters. We obtained verbal consent for blood testing and for vaccination. And for testing, results were hand delivered, and any positive result was discussed with an interpreter present. So as you can see here, we were able to screen 1,074 children so that they could enter into the they would have their complete documentation for entry into the school system. The lead testing program identified one child with an elevated blood lead level of between 5 and 9.9 micrograms per deciliter, which requires follow up by the lead level service, and then 9 children who had a level between 3.5 and 4.9, which is not considered significantly elevated. And so overall, it was felt that there was a very low number of people, of children in this population that had an elevated blood level, which was very encouraging. And I want to thank and recognize Terry Howard and the CLIP team for their work and for this data. So thinking about tuberculosis, so as part of this activity, so we were able to screen 998 people. These are children with a TB blood test, the QuantiFERON TB Gold, that had positive and negative results. 22 children tested positive for TB exposure. So that's 2%. And I think if when I was asked ahead of this event what I assumed the rate of positivity would be, I was guessing 10%. So 2% is a lot lower than I was estimating. And we were happy to see that TB exposure is not a huge problem in this population. The children ranged from 1 year old to 18 years old, and they were all referred for further care, which includes a chest X-ray and a clinical evaluation. Of those that were referred, there were only, of the 22 that were referred, there were only 13 that were evaluated. All of them were diagnosed with all of the 13 were diagnosed with latent TB infection. So there was no cases of TB disease in the population. There were 10 that started on LTBI treatment. So there were between the different regimens, the 4-month rifampin regimen was the most popular with 8 of the 10 starting on that. And of the 10 that started treatment, 4 at least at what we have documentation of, 4 completed treatment. So that is a fairly steep fall off the care cascade. 22 with positive tests, 4 completing treatment. I think that the issue there is that a lot of the data reporting is hard to assess in terms of its accuracy. That plays to, I think, the LTBI data reporting in the state in general. But there's complexities with this group of people in terms of tracking them between shelter sites. Some shelter sites have been consolidated, so they're moving between sites, moving between TB clinics where they're referred, and that has been a challenge. And additionally, I would say it's hard to get people from a shelter site to a TB clinic or a primary care clinic because they don't have transport. And so that may be another reason for some of that drop off. I want to recognize Jennifer Cochran, who's the former director of the Division of Global Populations, and our public health nursing, TB nursing led by Anna Hipshin, and our public health epidemiologist, Kavita Gadani, for this data. So I also want to talk about our DPH vaccine unit and their activities. So essentially what happens with vaccination is we send a vaccine unit with nursing to sites. They document vaccination history for children and adults into the Massachusetts Immunization Information System. And then if they need vaccines, they then administer vaccines. So these are large EA shelter sites that we're talking about here. They've visited 57. This was, as you can see, the dates. This is as of kind of January until present. Over 1,000 children assessed, 1,600 plus people vaccinated, 4,728 vaccines administered. Primarily routine pediatric vaccines, so hepatitis A, hepatitis B, MMR, Tdap, polio, varicella. In addition, we're also vaccinating at family welcome centers. Those are mostly COVID and influenza immunizations, at least they were earlier in the year. We've now started to administer the routine pediatric vaccinations at those sites as well. I want to thank Pej Talabian and Catherine Auger-Pierre for these data in the vaccine unit. So, I think this is a photo of a vaccine and public health screening event that was offsite. This took place in the fall, and so you can see it's very well staffed and very well resourced. We have privacy screens, we have signage in Haitian Creole, interpreters present. What you don't see in this picture are clients, people staying at EA shelters, getting vaccinated or getting tested. And so, I think it leads us to sort of question how we can improve our work. And what have been the barriers to sort of uptake of our interventions? I think one is that in general, as expected, there's low literacy for our type of healthcare for people that are arriving. I mean, a lot of people are arriving from places where they don't have strong public health infrastructure, that don't have strong healthcare delivery, and so may not be either comfortable or accepting of the way we deliver care. As I already mentioned, there's difficulty tracking people across shelters and healthcare facilities. We're currently using REDCap as a data collection system, but there's no medical record that's traveling with individuals beyond their minimal paperwork about where they may have been vaccinated previously. Again, limited transportation. And then I think a really big issue is that there's lack of primary care provider availability across Massachusetts. I hope we'll have some time to talk about that. And then stigma. So, there is a lot of misunderstanding around people who are living, recently arrived people, and whether they as sort of vectors for disease, right? We've gotten lots of false alarms about TB outbreaks in shelters, and then from those, lots of misinformation that spreads through communities, which I think saps our public will to support people who are arriving. So I'm hopeful that we are going to improve our work. We're currently planning comprehensive shelter-based public health events, and these comprehensive screening events are going to include TB screening, HIV screening, hepatitis B and C screening, sexually transmitted infection screening. It's going to be led by local boards of health. It's going to be supported by DPH. And then people are going to be referred to community health centers for primary care. And this first one will likely be taking place in Lowell later this spring. There's also another mechanism called the Refugee Health Assessment that offers 2 visits for people who are qualified as refugees, but can then be led into primary care. And so we're hopefully going to be leveraging those to help people staying in shelters get assessed. And then, figuring out how we can support existing primary care providers to manage infectious disease and provide access to people staying in shelters. So this is my 3rd year anniversary at DPH. I joined the team in the middle of the COVID pandemic. I essentially transitioned from health equity work, but I feel like I'm doing health equity work in my current role. I just want to say most American families have an immigration story somewhere in their history. It's often a story of struggle, of assimilation, of finding their way. And I think that these immigration experiences, either recent or past, along with the diversity of that comes with immigration, makes us a strong society. And I'm really proud to be working with my colleagues at DPH and state government, along with all of you, to support people who continue to arrive in our country and who are seeking a better life. So I will stop there, and I will turn it over to our next speaker.
Thank you so much. I do notice that there are some questions in the chat, one about possible service cuts, and another question for Dr. Tierney. So I'll go ahead and get started. Maybe we can answer the questions in the chat. So hi everyone, my name is Yesenia Mejia Urieta. I am a program coordinator at Boston Healthcare for the Homeless program. I'm working specifically with our transgender program, as well as our asylum clinic and our newly relaunched, or soon to be relaunched, immigrant-friendly multicultural drop-in clinic. Although we are not a program specifically for immigrants, we are a federally qualified health center, and we'll get more into that early in this presentation. But we do sit at the intersection of homelessness and those intersecting identities that produce homelessness. So Dr. Tierney laid that out very, very well for us. So we're going to be talking about how we as a program are navigating the demographic changes, as well as the growing diverse language needs at Boston Healthcare for the Homeless program, because we too are on the front lines of several waves of new immigrant arrivals in Massachusetts, not just this most recent one. So before we start the presentation, we would like to do a quick land acknowledgement on the following slide. We would like to acknowledge that the land that we are meeting on today is the original homelands of the Mashpee, Wampanoag, Aquinnah, Wampanoag, Nipmuc, and Massachusetts tribal nations. We are a little short on time, so we might not get to cover everything, but generally we do want to just talk about our organization-wide efforts, our programming, challenges and successes, and with some best practices on combating stigma and meeting health needs of newly arrived immigrants. Firstly, we are a federally qualified health center, so we do not turn anybody away, regardless of race, immigrant status, gender identity, and we do strive to make our clinics, our physical clinics, we have several, like I think over 33 of them, including our main site. We are at family shelters, we are at emergency shelters, emergency adult shelters, as well as different other scatter sites, and of course on the street. So we do try to include welcoming signage. On the next slide, Maggie, maybe you can talk more about the history of like the evolution of how we even came to having an immigrant health committee.
Sure. And thank you so much, Dr. Ahonkai and Dr. Tierney and Moharab for all that you've already shared. So I'm a family nurse practitioner with Boston Healthcare for the Homeless, as Yesenia mentioned, and we have had some sort of immigrant health focused work since at least 2013. So just to say that although there's been a lot of new challenging needs more recently, we have been attending to our immigrant and limited English proficient patients for many, many years. So just to say that this is something that we've been trying to do for a while and putting in some systems and structures in order to do this. And so we have an immigrant health committee. It's led by Dr. Aura Obando, who you can see in the pink here. And we meet weekly and really are something that we try to address both patient-facing needs as well as recognizing staff needs. So we have a lot of staff who are also have immigrant backgrounds, and this came up pretty pointedly during COVID when we were trying to do symptom screening and noticing that we needed to have symptom screening in offering in multiple languages among our staff. And so this is something that we really try to do and have it be both ways towards staff and towards patients. Let me see if my advancing, here we go. Back over to you, Yesenia.
Yeah, thank you. So I mentioned briefly our Oasis Clinic, which is currently on Thursdays, but we will be relaunching on Saturdays as a drop-in clinic. We use that term loosely because anyone who is a service provider currently working with the immigrant populations, usually people are most interested in meeting their material needs. So the purpose of this space is not only to provide a safe space and a welcoming space for people who have different language needs or who do have like an experience of immigration or migration. We do try to do outreach to meet people's medical needs, but through firstly building rapport, offering case management. Hopefully we will be offering legal screenings, and we do that throughout the program as well. We do have case managers who are very well experienced in at least connecting to someone who is able to do a legal screening. We offer medical visits in a very low threshold way. People can sit down, and if they decide that they want to see a nurse that day, then we have a nurse that is available for a visit. We can go to the next slide. I wonder, Maggie, where we should skip to.
Yeah, that's a great question. So we want to also make sure that there's opportunities for you all to ask questions. Just to note, we have internal policies. It's really helpful in your own institutions to have internal policies for if and when law enforcement or immigration enforcement were to come unexpectedly to your institution, and make sure that policy is accessible to your staff. We have an internal website and we post those policies for staff at the internal website. Language access, I wanted to put a very quick point in that in addition to having in-person interpretation, which is really invaluable, it's also important and helpful to make sure that the staff who do declare themselves to be bilingual speaking, that there is a bilingual verification process for them so that there is some type of a standard for how quote unquote bilingual somebody needs to be in order to work with that patient population. We took a couple points from the MGH colleagues on having a badge backer. And so this is really to make accessible interpreter services. And so that people don't have to dig around for it, look on their phones, just attach it to your ID badge. I am going to skip towards the emerging strategies. So I do want to say that when this was already a couple of years ago when we were starting to see an increase in migrant individuals coming. And so there was a lot of news in the media about people who are having to board in the ED, people whose quote unquote chief complaint was one around housing or social needs and not necessarily around medical needs. And so our colleagues over at Boston Medical Center were seeing lots of families experiencing homelessness. And for a period, we opened up our own lobby across the street at Boston Healthcare for the Homeless to families that couldn't fit in the BMC emergency department. So I think we hosted a total of nearly 60 families over those few months. It was extraordinarily labor intensive to do, as you can imagine, and I think just goes back to one of my main refrains is this work is easier to do in community. This work is easier to do with more support and more funding. And so, short of having some type of a national funding or coordination strategy, this is really difficult to do, and especially coming from a federally qualified health center, we're already at baseline a pretty resource scarce place, and so being able to have more supports in order, similar to as was mentioned in the chat earlier with colleagues like La Colaborativa, that these are organizations that need a lot of support in order to continue to do the good work that we all do. Really trying to build up case management capacity. So working with case managers to help case managers work to the top of what they are able to do. And that includes some immigration related support. So renewing or applying for TPS visas, trying to help people access emergency assistance shelters, trying to identify where people's immigration hearings are going to be and helping them to get to those hearings so that they don't miss them. But really trying to maximize what your case management can do is really important for family support. And our family team at Boston Healthcare for the Homeless, it collaborates with the Department of Public Health, and there's a lot of outreach happening at some of the overflow spaces like the Roxbury Recreation Center and many other family shelters. And I do want to point out that most of the data that we have is around family homelessness, and that's because there is a right to shelter for families in the state. But for example, at Boston Healthcare for the Homeless, we're also in lots and lots of spaces seeing people who are migrants and non-migrants experiencing homelessness in non-family shelter spaces who are not in family units. So we see lots of folks who are at the Pine Street Inn, at the Southampton Street Shelter, at Woods Mullen, who are not part of family units. That means that they're not part of the emergency assistance kind of coordinated funding that the state provides. And so we really sit at this bridge of structures where there is some amount of funding coming into to support. And as you can see, it's still not enough to meet all the need. And then a lot of individuals who are essentially without any type of coordinated support. And so we're really trying to work with folks who are not in those spaces. And that's proven to be really difficult. So language access, we're great at English. We're great to some extent in Spanish. And we've been seeing lots of folks coming who speak other languages. So Haitian Creole, which we already know at baseline in our patient population, we're not great at meeting the clinical needs. And we can see that in the results of management of chronic diseases, routine health screenings, that when you look by language, Haitian Creole prior to this influx was lagging behind others. And so really trying to meet the language demands. Just a plug for support is that health centers pay for their own language line, so to speak. And so all of the increase in demand for language interpretation which I would say has doubled, in some months tripled, is really something that is not necessarily reimbursable for federally qualified health centers. And that is really a growing financial strain. Staff support, we're seeing lots of people throughout our program who are not necessarily familiar with working with immigrant patients, who are all of a sudden needing to know, which labs do I order? Which medications do I prescribe? What do I do? How do I get the language line? And so really trying to provide as broad of staff support as we can. and not just to a small group of people, but to as many people as possible within our program. And then some of the additional challenges, shelter capacity is really a struggle. I think both in the non-emergency assistance shelters, so in places like Pine Street Inn and at Southampton, shelter capacity where folks are needing to be, are in overflow spaces there. So on mats in lobbies once all the beds are filled. And these are places that are oftentimes filled past capacity many nights. And then the shelter capacity for families. So being in a right to shelter state and being in a place where there's been a new limit placed on how many families can be in shelter, and that limit is 7,500 families. And now with a time limit on how long families can be in shelters is really, when we know that it takes much longer to access housing is a real challenge. And so I'm gonna stop there, and I'll stop sharing. Yesenia and I have, probably our own hour long of content that we would love to share and talk about and get your input in. But we'll leave it there for now.
Thank you for those wonderful presentations. And there's been active answer and question and answer going on in the chat, and we're trying to share that with the group. I'd love to take this opportunity of a few more minutes to have more discussion and question and answer. So there are, several comments, thanking DPH for their work. Questions about what resources are being made available to individuals and families, including around mental health, around basic sustenance. I'm not sure if others have responses to add there. And then an important question about how where these resources are coming from, and kind of the tension between providing resources for a growing population and if that's taking away from the needs of others living in Massachusetts. I'll leave it to me. I'll let everyone contribute to one thing that they may not have already put in the chat, starting with Yesenia and Maggie. Final comment. Do you have anything finally you want to share, Yesenia or Maggie?
If I could take the opportunity to prompt them, I would love to hear about the question about mental health services. How's that been? That's been a challenge for the whole population. I would love to hear your experiences there.
Yeah, huge challenge, huge.
Yes.
And this was a huge challenge before we were in this space. And actually, Yesenia, you unmuted. You are a newly minted social worker, so I'm going to turn it over to you.
Yeah, I was gonna say the same. I think it is a challenge. Maggie and I do coordinate on our asylum clinic as well. And after asylum evaluations, we do screen for if people want or need mental health support. And obviously, just in general, our patient population, when they arrive to the doctor's office, they also are screened for the same. And not only is it an issue of language access, but there's also across the state and probably across the country, there are very long wait lists to see therapists. So one idea that we have been, it's been a little rocky, is offering groups, and obviously our drop-in clinics, because therapy and mental health support can be like healing work can look a lot of different ways. So we're trying to be as creative as we can be.
Thank you so much. We're in the last minute here, and I want to say, unless I think Dr. Tierney wanted to make a comment, but thank you for this wonderful discussion. We will share this information back to you. We have your contact information from registering. This is not the end of this conversation. We'll continue to have a forum to advance. As we all see, there's rich opportunity for much more to be done, much more to be shared, and we would love the opportunity to do that. Thank you so much for joining, and have a good rest of your day.